continuing with the health assessment as the module or the course unit. And today we are basically going to look at the cardiac assessment. So in the cardiac assessment, we are looking at the circulatory system. And here basically I want us to start with the introduction, which I'm looking at the system assessment. So when you're assessing your patient, in most cases, you have to assess all the systems. Unless they have come and they have a complaint whereby it is leading you to the cardiac system or the cardiovascular system, then there you can basically focus on the cardiovascular system. So the key components remain constant, but priorities vary based on the patient's needs. And as already mentioned, when you see the patient has come and his response is leading you to more of the cardiovascular system, then you'll have to concentrate more on the cardiovascular system so that you can be able to get clear information and also the data that can help you actually get the right diagnosis, and also that can help you in the management of your patient. So I want us to look at the health history that we need to pick from these patients when they come to you, and you basically want to look at the cardiovascular system. Which other histories are you going to pick, and what is the importance of such histories in relation to the cardiovascular system? So the importance of this health history is basically for recognition of the cardiac symptoms that are crucial for nurses in the cardiovascular disease settings. So when you get these histories, they can help you to understand whether your patient has those symptoms that can lead to cardiovascular system, diseases. Then the patients also should identify and manage symptoms promptly. So it is very important for you to understand also as you educate them in relation to their conditions, and they can be able to manage their own system, their own symptoms as you explain to them. Then what could be the barriers? There are also some barriers that can actually hinder us from managing our patients. So as you're getting these histories in relation to the cardiovascular system, we are also going to pick some of the barriers that can hinder you from managing this patient appropriately. So there can be lack of knowledge about heart disease. So you be talking to your patient, but the patient may not be actually knowing anything. But even you, the client, you should be having the knowledge and the understanding about the cardiovascular diseases, because the patient may express the signs and symptoms, how he's feeling, but you, the health worker, should also be having the knowledge on how to categorize, on how to diagnose, and how to understand that this is a cardiovascular disease. Then also attributing symptoms to benign sources. So this is also very important so that you can be able to understand the cause of these conditions when the patient is explaining to you what could be the predisposing factors to this kind of conditions, so that you can be able to health educate your patient. Then also denying symptom significance. You can also be when you're asking the history from the patient may be able to explain to you, but as he's explaining to you, you'll also realize that this patient is having some kind of denial, because some of them, they feel like this is traumatizing psychologically when they know that you have such kind of conditions. So some of them can be expressing, but you'll realize this patient is actually trying to deny the condition he's having in relation to the history he's giving to you. Then also feeling embarrassed about symptoms. I've already tried to say it all. Some of them feel they're embarrassed. Some of them feel, why is it that they're the ones having such kind of conditions? So when you're talking to these patients, they may decide not to tell you all the history. They may decide to actually hide some of the symptoms because they feel so embarrassed, but they don't know that these are histories or this kind of information can help you, the health worker, in managing them. Then also the educational interventions. I realize that in the next slides, we have study results on an intervention's impact on Latina's kind of knowledge of cardiovascular disease risk factors. So there are some other risk factors that people can be having or can predispose someone to have a cardiovascular disease. But then according to the study that someone did, Latinas, he has actually given us the idea on how to intervene in order to help someone not to get this kind of conditions or not to predispose someone in relation to these risk factors. So the common complaints that these patients can always give you, one of them is chest pain or discomfort. And you know where the heart is, it is within the chest region. So they will tell you, I don't feel comfortable and I feel pain, maybe on the left hand side where the heart is located. So when they express that, then you start suspecting that this patient could be having a cardiac condition or a cardiovascular system condition. Then also pain in other upper part areas. It may not be basically on the side of the heart, but it can be radiating to any other part within the upper region of the body. So when they are explaining to you, you have to be very keen enough to relate and articulate some of these symptoms, how they radiate, the locations, and the aggravating factors, and so forth. Then also, some of the common complaints can be dizziness, syncope, or changes in the consciousness of these patients. Some of them may end up being dizzy and they can even faint or collapse. So you have to find out from them, because when the heart is overwhelmed or the heart has pumped trying to compensate its activity, the client can end up with dizziness if the heart fails to supply enough blood to the brain. And we very well know that the brain carries oxygen that it supplies to the vital organs, and our brains are one of the vital organs. So in case this patient fails, the heart fails to actually supply enough blood to the brain, that means that the patient ends up with insufficiency of oxygen to the brain, and when they get dizzy, they can easily end up being they end up collapsing and they become unconscious and so forth. If they are not helped, some of them can even end up dying. Then intermittent claudication or rest pain. This is basically whereby the patient feels the pain even when he's at rest. This patient is not doing anything, he's just seated or he's just lying, but he's not comfortable, he's feeling pain. So this is also not right for our patients to feel chest pain or any part of the upper body whereby the patient will express that even when I sit, even when I'm not doing anything, I feel a lot of pain around my chest region or around the other part of the body, depending on where the patient will express. Then also palpitations or tachycardia. Palpitations is basically the increased rate of the heartbeat. Tachycardia is when the pulse is greater than the normal range, and this is not normal. This shows like the heart is trying to compensate, the heart is trying to beat faster, which is not a good sign. And when a patient tells you of such a complaint, then you should start relating to a heart condition. Then also peripheral edema, weight gain, and ascites. Our patients can come to us and you see the patient is having edema. There is weight gain. Weight gain may not be because the patient is healthy, but can be just because the patient has developed edema. So when you see these kind of symptoms, don't take them just as light as you may think, but this can be something that you need to dig out, to intervene and find out exactly what is causing this peripheral edema, what is making your patient to increase in weight, and why is the patient having ascites. So it is not a good sign, and many of them may complain of this when it has advanced. Then shortness of breath or dyspnea. Some of them may also tell you, I don't feel well when I'm breathing, I feel I don't get enough air, and then also I have difficulty in breathing. That is dyspnea. So it's not right for our patients to have this kind of complaints. So you need to intervene and saying, I'm feeling tired. even when it cannot actually walk for a long distance. So this is unusual fatigue, whereby the patient is actually not doing anything or any work that is heavy, but the patient is expressing tiredness. So these are signs of cardiovascular conditions. So for the case of chest pain, it causes the causes and the differentials. So you look at characteristics of common causes of chest pain. You have to find out why the patient is feeling chest pain. You have to go in depth to find out, because it may be something else. But then you also have to look at was there a trauma? How are the lungs of this patient? So that you can be able to categorize or to differentiate from the cardiovascular conditions. Then also assessing the quantity, location, and quality of pain. You should be able to also know how much pain is your patient having, because you can be able to assess the amount of pain in relation to maybe the facial expression, or the patient may tell you, you tell the patient from this first finger, 1, 2, 3, 4, 5 is moderate, 8 is like that, then maybe 10 is extremely severe pain. So the patient may tell you, I feel the 8th. Then you start now rating the pain levels or the severity of pain for your patient. So that can mean the quantity. Then the location, the patient may tell you, I feel pain on this side of my chest. I feel pain at the apex, this part, and they will be able to show you where they are really feeling the pain. So the location of the pain will also help you to understand whether this patient is having a heart condition, or it is on the other side, which is maybe the lungs and so forth. So you should be able to know the quantity, the quality, and the location of your patient's pain within the chest region, of course. Then identifying precipitating events, duration, aggravating or relieving measures, and also associated signs. So this basically is trying to tell us that when your patient is complaining of pain, what should be the precipitating factors? Like if the patient is having, he has said he has pain, yes, but now what could he have done that has made him to have the pain? Sometimes they'll tell you, when I lie, I feel the pain. And how long has it taken? That is the duration. Someone may tell you, when I start feeling that pain, it takes like 1 hour for me to get relieved. So the duration will be the 1 hour when the patient is feeling the pain. The aggravating factors is like what stimulates the pain, and also the relieving you should be knowing, because you can be encouraging your patient to have those relieving measures so that he does not feel the pain. He may basically tell you, when I sit or when I lie in a sitting up position, I feel a bit relieved. So you encourage your patient, especially our patients who have the cardiovascular conditions, we have to encourage them to always lie on a sitting up position to relieve a compression on the heart, and that will help them also get relieved from the pains and associated signs. When they feel the pain around the heart, what are other things that they feel besides the pain? So that will be the one that will be associated to the pain. So they will explain that maybe when I'm feeling the pain, I feel dizzy, I feel like I don't have enough breath, so it is associated with the pain. Then also the important points. There are some important points that we really need to put into our fingertips, that when these patients come, we need to know about this. Severity and duration do not depict seriousness. So sometimes when these patients come, some of them may be very serious, some of them may change their facial expressions. It doesn't mean that really they are feeling severe pain or the pain is too much and so forth. So we have also to take that in consideration, because I want to give an example whereby we can get patients who have gotten an accident, and you go into the scene, but you see one is over yelling and expressing a lot of pain, but there is this other one who is just quiet and very calm, and you may end up bypassing the one who is very calm, and you go to the one who is yelling, and yet the one who is calm is the one who is seriously injured. So when a patient comes to you, some of them can just express because they need your attention. So you have also to look at some of these considerations, and you should be able to really assess and get enough history to help you understand the severity of this pain, so that you can be able to intervene appropriately and not intervening in a way that is so exaggerated and may end up mismanaging this patient by maybe giving drugs that do not actually match with the condition. Then multiple cardiac conditions may coexist. So you have also to know that some of these conditions, when you identify one, you may realize that there is another one. So when you get a patient who has a cardiac condition, you may want to know what could be the cause of this cardiac condition. This patient might be having hypertension, some of them might be having diabetes, and some of them might be having some other congenital abnormalities. So it's very key and very important for us to know and to understand that some of the conditions our patients present with may not be only one condition, but there can be other predisposing factors which could have made a coexistence of some other different other conditions within the same patient. The symptoms of acute coronary syndrome. A syndrome is basically looking at a combination of signs and symptoms. So this acute coronary syndrome is looking at the signs and symptoms that a patient can present in relation to acute coronary disease. So the prodromal symptoms are basically looking at the common conditions. That's what this statement is telling us, or this word prodromal is basically looking at those key kind of conditions or key kind of symptoms that these patients can always present to us, the most common ones. When a patient comes to you and has acute coronary syndrome, what are those common symptoms that they always present with? That is what prodromal means. So there is unusual fatigue, shortness of breath, sleep disturbances, anxiety, fleeting chest discomfort, and I remember we mentioned them in the previous slides. So they can come with those prodromal symptoms, and you may be able to understand this patient has ACS. Then often it is attributed to benign issues and they need specific questioning. So when they present to you, you should be having some key questions that you should ask these patients, because you can even be able to know that this can be either benign kind of condition or it may not be. So the questions that we have to give to these patients, or which you want to find from these patients, should be specific, and you should be having reasons and the ideas on why we are asking those questions, so that their responses we are able to articulate and to the topic that we are trying to find out, or the condition that we are trying to find out from our clients. Then the variety of symptoms. There are other different other symptoms that these patients can present. So there are so many other various kind of symptoms that these patients can come with. So one of them is chest symptoms. About 50% of these patients with acute coronary syndrome can present. Then other symptoms that may include is upper back pain. Some of them can say, I'm feeling pain on the upper back around the shoulder. And then others can have pain around the arm, because it can just radiate following the arm, or the neck pain, and also epigastric burning, shortness of breath, unusual fatigue, and diaphoresis. So some of them can come when they have all these symptoms, but you have to really ask a number of questions or get history from these patients that can lead you to proper diagnosis. So we need to have some special considerations in relation to this condition. So what could be the special considerations that you have to look at as a health worker? So you have to look at the neuropathies, and it's basically in elderly and in the diabetic patients. And as I explained in the previous slide, I said some of these conditions, the heart conditions, can come when they are coexisting with another condition. it may not be only one condition, but they can be coexisting with other conditions. So when these patients come, you have to ask them about it so that they can be able to tell you that maybe I'm having this neuropathy. Neuropathy is like numbness or effect onto the nervous system or the patient's nerves, whereby when maybe when he gets burnt, when fire is put around his soul, he will not feel. He can even touch fire, but will not feel the pain, but the fire is burning him. Those are some of the issues that some of these diabetic patients end up with. So we have to ask all this so that we can be able to treat the coexisting conditions. Then also symptomatic acute coronary disease. There are some of these conditions whereby the patient will not present with any sign. So asymptomatic meaning no sign, no symptom. So the patient comes with no symptoms of acute coronary syndrome, and that one is a silent ischemia, whereby the patient's coronary arteries are being destroyed, but the patient does not feel any impact of any kind of maybe pain. He does not feel any difficulty, but there is something happening in his coronary blood vessel. So we have to also put this into consideration, and that is a very special consideration. And these clients can even get a slight symptom and they can die. Then you will fail to understand what could have caused the death of this patient. And yet actually the patient has been having the problem, but it was asymptomatic. So how do you diagnose? So the diagnosis of acute coronary syndrome, there are basically some tools that we use, the diagnostic tools that health workers use for diagnosing this condition. The 12-lead ECG and serum biomarker analysis is necessary. Why should we use this? It helps us understand how the heart is pumping, how the heart is working. So when they use this, according to the results or according to the findings, they are able to interpret. The cardiologists are able to interpret, and they can be able to tell you the effect which is on the patient's heart, and they can be able to understand what is going on with your patient. So ECG is very important. Then to determine unstable angina and then acute MI. So sometimes this patient can come and will tell you, I feel a lot of pain on the left hand side of my chest. So that can be angina, and angina pectoris is a very, very bad kind of pain that these patients always experience when they have a heart condition, and it is associated with hypertension. So patients with hypertension, in most cases, when their BPs go so high, they get that angina pectoris. So it is a condition that reflects that there is a problem with the heart. So this can be a way in which we can be able to also detect or be able to diagnose acute coronary syndrome. Then history in cardiovascular assessment. The histories are very, very important because it can lead us to the diagnosis. So when these patients come, we are supposed to carry out a comprehensive history. And I remember when we talked about the health assessment, we said we have to take both the objective and the subjective data. And when you get this data, we can be able to actually interpret and come up with the real condition or the diagnosis, and that's when you shall be able to manage. So history in cardiovascular assessment is very important. Then also the epidemiologic studies link certain kind of conditions or behaviors to this kind of conditions, and they say some of this can be the cerebrovascular disease, and also it can be the pulmonary acute disease. And when these conditions come in, you realize this patient can also be having the acute coronary syndrome. So most of these conditions actually coexist with the other. So when you realize that the patient has this condition, just know that there can be something also happening on the other side of the system, because when you look at the cardiovascular system, it's more related to the pulmonary system. So most of these conditions, when they attack the heart, they can also be attacking the respiratory side or system, whereby when we talked about the signs and symptoms, we talked about difficulty in breathing, and breathing basically is related to the respiratory system, the pulmonary system. And when we look at this, we have to be able to articulate and relate things so that we can be able to connect the different conditions and the different ways in which our patients present and how they are feeling. So the health assessment questions, what kind of questions are you going to ask your patient? So there should be some specific questions that are very relevant to the condition that your patient is presenting or expressing. So the general health questions that you may ask is, you have to inquire about the changes in health over time. How have you been feeling? Is there anything that you're feeling different from time before this? And the patient will tell you, yes, I've not been feeling fatigue, but one of these days, even when I've not done anything, or just when I walk a short distance, I feel I am fatigued. So that one is a change that has occurred. So you have to find out, why is this patient now feeling this different? Like he has not been having it, but now is feeling it. Why is it happening at this time? Then also ask about the existence of a cardiologist or a primary health care provider and frequency of checkups. You need to find out, have you ever gone to a cardiologist? And if he tells you yes, then you just suspect this patient could be having a cardiac problem, whereby sometimes they're in denial and they may not be able to open up to tell you. So sometimes when they go to one cardiologist and they tell them the condition, they feel not contented, they feel denying, they think maybe this doctor has not seen it well, so they feel they want to go to another person, and they expect you to tell them maybe they don't have. But the moment you ask them and they tell you, yes, I've ever gone to a cardiologist, then you should be able to find out in depth why, what were you going to look for from the cardiologist, what was the problem that took you there, how were you managed, what was the advice, and so forth. So this patient might be on denial, whereby he's moving from doctor to doctor. So when you ask such a question and he tells that yes, I went, then find out exactly what transpired, why was he actually going to look for the cardiologist, and see how to help this patient to understand his condition. So there can be also questions that can help you get the risk factors. So you have to question the patients about their heart disease, and when you ask them, there should be other responses that can help you understand that this can be the risk factor to this kind of condition to my patient, and you advise them accordingly. Then also emphasize the importance of awareness for effective lifestyle changes. So you also have to emphasize on that, because some of our lifestyles predispose us to some of these conditions. So when you ask your patient during the time of health assessment and they tell you some of these responses, and really understand as a health worker that this can predispose my client to a cardiovascular condition, then you should be able to advise him or advise her accordingly. Or if he has a cardiovascular condition and he's trying to deny, try to talk to him, encourage him and motivate him to live with it positively. Then also help them not to go into a complication, because when they realize that they have these conditions, this is for life. Some of them can even refuse to take drugs. Some of them may refuse to go back for checkups with their doctors. So encourage them so that they can be able to also survive and live longer. You can also get some family history, because some of these conditions are hereditary. A patient can get hypertension, yes, but most of them, it can be running in families. Then also diabetes can be running in families, and these conditions, these chronic conditions, are conditions that have predisposed most of our clients to cardiovascular diseases. So we need to talk to them, and then we see how to advise them, and this can help them live longer than they would expect. So the cardiac disease in a family you should get to know. So inquire about sudden death, non-coronary heart diseases, or uh, cardiac diseases. Find out from them, is there someone who had such a condition? Is there someone who was maybe having hypertension? Is there somebody? You ask all those relevant histories, relevant kind of conditions that can relate to the family kind of maybe acquiring of this condition. So when they respond to you and it is positive, then you suspect this patient might be having this kind of condition. Biochemical, neuromuscular conditions like the diabetes and so forth, find out from them and they'll open up and they'll tell you. Then also discuss the genetic testing and disorders that are associated with genetic abnormalities. Some of these people can be having such kind of abnormalities in relation to their genes, and this can predispose them to some of these conditions, and can be through family line. So when you talk to them in relation to family history, be keen enough to ask questions that are relevant for you to identify the problem with your client. Then on the social history, talk about the medications. When you ask these patients about the medications that they are taking, find out how they are taking these medications, what kind of medications are they taking, for what kind of conditions, how are they taking them. Then they can be able to really tell why this patient is coming to you, what this patient is actually going through, and this can help you manage this patient appropriately. So collaborate with the healthcare providers for a complete list of medications. So you have to know how many drugs this patient is taking, what kind of drugs is this patient taking, and why is this patient taking this kind of medications. Then assess medication adherence. Is the patient really taking these drugs appropriately as being advised by the health worker, or the patient is actually not adhering to the treatment, which is aggravating his pain, which is aggravating the condition and making it worse. Then also the side effect awareness. Let the patient be able to know and understand the importance of him taking the drugs, and also let him be able to know the side effects of these drugs. The side effects are very key for this patient to understand, so that they can be able to comply with them, because taking drugs for life is not something easy. So when you talk to them and encourage them, then they can able to adhere even with the side effects of these drugs. And also understanding of the medication regimen. They should be knowing how many drugs or how many tablets they are supposed to swallow, how many times in a day, and it is for how long, so that they can be able to follow them appropriately. So it is very important for us to inform them about this. On nutrition and metabolism, dietary strategies emphasize the importance of diet in managing cardiovascular risk factors, because some of our nutrition can also affect, when you feed on certain type of foods, they also affect our cardiovascular system and can cause us these cardiovascular conditions. So some kind of foods that we take can be a risk factor to some of these conditions. So we have to talk to them and also gather information on self-monitoring of blood pressure, blood glucose, and the weight. I talk to the patient that he needs to monitor his weight, he needs to monitor his blood pressure, and he needs to monitor his glucose levels. These are all very important and related to the condition. Then assess the patient's knowledge of target goals and challenges in achieving them. As you talk to him or her about monitoring his blood pressure, find out whether he has a challenge, maybe has no BP machine at home, or even where he goes to try to check on his BPs is far. So try to talk to this patient and help him get a reliable solution on how he can be able to monitor his vitals. Then the blood glucose is very key, because some of these conditions are caused by diabetes, so they should be able to know the blood glucose. and also the weight. Our weights, when you're very heavy, it can also predispose you to hypertension, to cardiovascular conditions. So you have to assess all these. Looking at the other things about assessing the patient's knowledge or target goals and challenges in achieving them, which I've already explained. Then explore eating habits, food preferences. People sell grocery. In most cases, their foods are very accessible to them. They just pick sodas, drink at any time they feel like. Those who are in the kitchen, they are able to eat anything at any time because they are there preparing. So all this is very important for you to find out and advise them in relation to the nutritional status predisposing them into these conditions. Then elimination, bowel and bladder habits. They should always be able to empty their bladder, empty the bowel. At the time you feel you want to go to the toilet, please go and relieve yourself. Otherwise, it can also predispose you to urinary tract infections and cause more harm than good to the urinary system. So identify the typical habits and not changes. So you have to find out from the clients, talk to them, find out their challenges, and advise them accordingly in relation to the bowel and bladder habits. The other one is to discuss the potential side effects of cardiac medications on the GI system. So some of these drugs can cause other effects onto the GI system. So you have to talk to them and also advise them. Sometimes there can be nausea, sometimes there can be maybe increased appetite, sometimes there can be low metabolism. So you have to talk to them in relation to the drugs that they are taking. So the activity and exercise, assess activity tolerance for these patients. And I remember I said some of them may feel tired even when they have not done much. So for the case of the activity, advise them in relation to how much they are supposed to do. Talk to them on the exercise, how much exercise they are supposed to have, so that they don't really overdo the exercises or do too much of the activities that can predispose them to some of these signs and symptoms. So assessing activity tolerance, they say evaluate the changes in activity tolerance, especially during the past 6 to 12 months. Ask them, what have you been doing? What kind of activities? Do you do exercises? What kind of exercise? For how long do you do it? And so forth. Then note symptoms like angina or shortness of breath during activity. And I remember saying this several times. The patient may tell you, I feel pain, maybe when he's doing exercise or when he's doing a heavy duty. Then he'll tell you, I feel shortness of breath and so forth. Then sleep and rest. Encourage them to have enough sleep, enough rest. So sleep related events, also find out when you're resting, how do you feel? Do you get shortness of breath? Do you have difficulty in breathing? What happens? Or do you have chest pain? And which side of the chest? So all those things you have to know and they can help you in the management. Then explore where the patient sleeps and changes in sleep habits, which I've already tried to hint. Then discuss the signs of worsening cardiac disease during sleep. So when you're sleeping, how do you feel? Do you feel more pain, or the pain gets relieved? Or when you're sleeping, there's a particular side that you feel the pain is relieved than the other, and so forth. Then this can help you direct in the management and the advice that you're going to give to your patient. Then cognitive assessment, evaluate short-term memory, assess history of dementia, and then check for evidence of depression or anxiety, determine the patient's ability to read and comprehend English or any other language that the patient is able to read, then identify the patient's reading level and preferred learning style. Then also understand what information the patient perceives as important. All this you have to assess. So cognitive means just using the brain and the understanding. So you have to ask these kind of questions that can lead you to any kind of management in relation to maybe mental issues or mental disabilities, and you'll be able to understand what your patient is going through, and you'll be able to support your patient. This is a title So the written information in patient education, then also written information is valuable for patient education. Then consider patient's ability to read and comprehend information. Related assessments, which include checking for hearing or visual impairments, you should also do that. Then impaired vision may also affect the ability to wait, then also monitor BP, pulse, etc. and independently. So the patient may not be able to do this if he is not able to see. So if the patient is not able to see, if he has a visual impairment, then he cannot be able to measure his BPs because he will not be able to tell what it is. Even if he uses a pulse oximeter, he cannot be able to see his pulse. So there are some other factors that may hinder our patients from doing their own personal assessment to themselves. Then self-perception and self-concept. Self-perception and self-concept impact adherence to medical regimens. So sometimes our patients are fear and sometimes they end up not adhering. So this can be due to self-perception, the way they feel about the drugs, about maybe the medications you're giving them. So you have to also look at this, because if the patient has a different perception on a certain drug, then he will not adhere to the treatment. Then understand patients' beliefs and feelings about their health. We need to understand them. They have their own beliefs. They may say, I'm having this condition because they have bewitched me. So you have to help this patient understand that there are risk factors and there are predisposing factors to this condition, and really tell them exactly what has caused this and how they can go about with it. Because according to the way they understand, it might be how they believe and how they feel about their health conditions. So key determinants of adherence to lifestyle changes after cardiac events. You should also try to talk to them to understand the determinants on how they're supposed to adhere to this kind of lifestyle, because they have no any other option. Most of these conditions are for life. So you have to talk to them and encourage them. So the key questions for patients that you can find out from them if they have a challenge in knowing that they have such conditions. One of them is, what is your cardiac problem and what contributed to it? They may be able to tell you that I think I have a cardiac problem and this could be the reason as to why I have it, or this could be the cause. Then how will this illness impact your life? Then they will also tell you. That is after you have taught them, after they have learned, after they have understood all what is going around them with such conditions. Then how much control do you believe you have over this illness? They will be able to express and tell you openly. Then sexuality and reproduction. What is it all about in relation to the cardiovascular system conditions? So sexual activity changes in patients with cardiac diseases. You know, in most cases, the sexual activities need a lot of energy, and most of these patients may not be able to. So even their sexual activity changes. If someone has been that kind of active person in such, they end up deteriorating because they feel they cannot have the strength to do that. Then issues related to inadequate information, depression and fear. So some of them can have depression, some of them can be fearing to have those kind of things, and they end up actually not even reproducing. If they were supposed to have more children, they may end up remaining with the ones that they have. If they had not produced, they may end up not having, because some of these conditions will deprive them from these activities, and there's no you can have a child without a sexual activity. Then impotence as a side effect of medications, particularly the beta blockers. So some of these drugs also cause a negative impact to our sexual activity or the reproductive system. So some people may end up being impotent like the male, and they may end up not again producing. So some of these drugs can also cause issues in our families and can break marriages, because you become impotent, you cannot produce, and most cases people always separate unless they had children, and then now you the health worker, you have to come in and do a lot of counseling to this couple and encourage them to take care of each other, because one who has is not that he decided to have it. but it's something that happened in a way that even him, he never expected to. So the importance of discussing sexual concerns with healthcare providers, I've already mentioned why it is important. I want us to look at something on psychological demands of sexual activity. So physiological demands during orgasm, that's why most of them actually even get more pain in the heart, or they get more kind of distress, dyspnea and so forth during this time of physiological demands for orgasm. Then also mates expended before and after orgasm. So this is what happens, the physiological changes that take place during this sexual activity affects most of these patients. So that's why most of them cannot be able to tolerate the sexual activity and the reproduction, because it affects them so much in a way that some of them can even end up deteriorating and can affect their life. Then sharing information to make patients and partners more comfortable. So when you, the health worker, you are open and you really share this information to these to these clients or to these patients and their families, they'll be able to accept the situation, and they'll be able to go by it, and there they will also be able to protect themselves and be able to live longer. But when you don't share this information with them, they will end up going to have these sexual activities which will deteriorate their conditions, and they'll be having pressure in their families, and this person may end up dying very fast. Then reproductive history for women. So we want to look at women. How does this affect women's reproductive life? So importance for women of childbearing age with compromised cardiac function. So this information is very important to women. So when you talk to them, they will be able to understand that even if I don't have a child, it is okay. But also, this my life is very important, because when they end up having children, they end up producing very many children and so forth, they end up reducing their lifespan because the heart is overworked. Remember, when somebody is pregnant, even these children, the babies or the fetus inside the uterus, needs a lot of blood supply, and it is basically the mother that provides nutrients to the fetus and oxygen to the fetus. So there will be increased cardiac activity, which will affect this heart more. So when you talk to them, they'll be able to understand that when they are having this condition, it will worsen when they are pregnant. So even when they get pregnant with this condition, they will always be monitored, and they should always be near the hospital, seeing the doctors frequently, adhering with their treatment and their follow-up dates, so that they can be monitored and helped to deliver safely. Then includes information about the previous pregnancies, plans for future pregnancies, contraceptive use, menopausal status, and hormone therapy. So this is all very key for these women. So you should get the histories for these women in relation to their reproductive activities, so that you can be able to advise them in relation to maybe the previous pregnancies. How were they treating them? How did they go about the mode of deliveries? And then also plan for the future pregnancy if they still have to produce, so that you can be able to understand their situation and handle them appropriately. Then also contraceptive use, we need to know which kind of contraceptives should these women take, because some of them can affect more the heart, and then the other hormonal therapies. So all this has to be looked up around and known about, so that we can be able to help these mothers, these women, have a successful pregnancy in case they have to produce children, and they should be able to actually also have a live baby. Then coping and stress tolerance. What do we have to understand in this? Coping and then stress tolerance is one of the things that affects not only cardiac patients, but also other conditions. So some people get so anxious, they get so depressed and stressed, and because of that, they can get heart failure. So some of our clients with this condition, when they get so traumatized mentally, psychologically, they develop a lot of stress, they get depressed, and from nowhere, you're seeing the patient is having heart failure. So we should be able to take them through some of these lifestyles so they can be able to cope up, to understand their situations, and they actually prevent getting into this CAD and HF. Then depression linked to rehospitalization, physical limitations, and poorer quality of life. So, as some of these things, if the patient is stressed and the patient cannot cope up with his condition, they end up being hospitalized several times. And this is not right, and this is not good for both their health and their family. Then also, it affects their physical life. It breaks them down, and some of them can even end up deteriorating, and the quality of life becomes more poorer, or it worsens, and the patients can easily die. So we have to advise them, encourage them to cope up with this and tolerate all the stress around them in relation to this condition, so that they can reduce hospitalization, they can improve on their physical life and also the quality of life. Then assessing patients for depression and stress is crucial. So we should be able to assess our patients. We have realized that when they get depressed, when they are anxious, when they are stressed, they end up with heart failure. And when a patient gets a heart failure, this patient is nearer to the grave. Of the vascular events. Stress initiates physical responses linked to cardiovascular events. Then assessing sources of stress. So when a patient is people can cope up very easily, but there are people who can take time to cope up. So we should take time with these patients. Let's not give up with them, because we have different coping mechanisms, we have different thresholds for different moods or different situations. So we should not just leave these patients. When they have not understood you today, or they have not followed what you told them today, don't give up. Tomorrow continue, so that they can be able to cope up. So the coping abilities are different from individual to individual. Then consultation with mental health professionals for anxious or depressed patients. So when you're not able to handle these patients, please refer them. Even referral is actually a way of management or treatment. So sometimes on the side of us, the general nurses, we may not be able to handle this patient, but we may be able to help them access the mental health professionals, where they can be able to identify the cause of the anxiety, the depression, and they are given antidepressants that can help them actually cope up, and by that you have helped this client. So I want us to look at the roles and relationships. So patients with cardiovascular disease manage with complex regimens and technology. So some of these patients can be having a lot of complicated kind of conditions, and when they get this, even the management may be complicated, and also the technology on handling them will be complicated. So the way we manage these patients may not be the same. They may all have heart conditions, but they are not the same. The way they present may be different, or the level or the severity may be different. So that will also demand for more kind of complex regimens of the drugs that we give them, and the technology of assessing these patients. Then importance of social support for self-management. So we also need social support for these patients, especially their families, We need to educate their families. We need to counsel them together with their families so they can be able to provide the social support to these clients. Assessing patients' roles in the family. We also need to know what is the responsibility of this person in this family, the relationships in these families. How are they relating? Or every time the husband is quarreling, every time the woman is quarreling, and this can affect them the more. And if the man has a lot of responsibility in the family, this can also affect him the more and worsen his condition, and so forth and so forth. So we need to get to know all this so that we can be able to provide the social support then social support and patient and stroke. So sometimes they end up getting worse conditions, or their condition can worsen and they can easily die. And even the complication before death can be stroke. So we really need to find out how are these people relating in the family, what kind of support are they giving to this patient, so that we can be able to reduce some of these mortality rates. Then assessing living situations, primary caregiver, and support for health management. This is self-explanatory, and I think when you read this, you can understand who is supporting this patient, who is able to give care to this patient, does he have or he doesn't have, and if he doesn't have, what could be the problem, how am I going to support him, what advice can I give him, and so on. Then financial and insurance considerations is tailoring the plan of care. When a patient does not have finance, most of these drugs need a lot of money. So when they don't have money, this is also another source of mortality, because the patient will not be able to acquire these drugs, cannot purchase them. And when there is no good adherence, it can predispose to complications, and the patient can easily die. Anxiety, depression, what is in this slide, I've already explained in the previous slides. Yes, this is also explained. So what are the objectives in the title still? The objectives is to estimate right-sided heart function by observing the jugular vein pulsations. So when you look at this patient, when you're getting the objective data, you can just look at this patient and you can see the jugular vein is pulsating. That is one of the symptoms that can tell you. It relates the right ventricular and the systolic pressure or the preload. That is the CVP. So internal jugular veins also difficult to visualize. Then external jugular veins used for visibility. So the internal you cannot see, but the external you see it pulsating around the jugular region of it. So external jugular veins are visible spine, then disappear with the head elevation at around less than 30 degrees. So when you elevate the patient below this degrees, you may not see it. Then assess right internal jugular vein as it is anatomically straighter, so you can be able to see it. Then abnormal jugular venous pulsations. So the pulsations around the jugular vein can also show you that there is a problem with your patient's heart. You can read through this slide below this and can explain you how you can be able to know that there is a problem with this heart. Then inspection and pulsation of the heart approaches. So inspect, palpate, and auscultate the pericardium. So you can be able to do this. And I remember when we started in our health assessment, we talked about all these techniques, and you'll be able to know which one is normal and which one is abnormal depending on your auscultation, palpation, and the inspection. So systemic examination areas, you have to look at the aorta, the aortic area you have to see, and where do you get it from? In the second intercostal space, right of the sternum. So all these areas that you're supposed to assess, I've tried to put them clearly so you can be able to follow this and be able to assess those areas systematically. Epical impulse or pulsation, that is basically the apex of the heart, whereby you palpate for abnormal pulsations over each pericardial area. So when you palpate, you'll be able to identify how the pulse is, whether it is regular, whether the duration, whether it is irregular, and then the amount of the pulse, and be able to rate it whether it is normal or it is abnormal. So detection facilitated by the left lateral position, make the patient to lie on the left lateral position, indicating left ventricular enlargement if felt in the adjacent intercostal spaces. So you have to look at that, and when you get it, you're supposed to count, you're supposed to feel the bouncing, and if it is so strong beyond what is expected, then you know that there is a problem, the heart is strained. So you have to look at all this, do the palpation, and be able to differentiate the normals from the abnormals. So the heart sounds, we all looked at this during the time of health assessment. We talked about the different 4 types of the heart sounds, and here the slides have repeated themselves, and when you read this you can be able to relate to what we already learned in the other health assessment. We talked about friction rub, what it is and how it is actually associated with maybe the heart condition. So all this you'll find them as you read your notes, and you can be able to refer to the previous lesson that we had in the respiratory system assessment. So when you look at auscultation procedure, and the patient remains in a supine position during auscultation, the diaphragm of the stethoscope is used to identify the S1, S2, and the abnormal sounds. And we talked about the abnormal sounds. Then left lateral position aids in detecting the S3, S4, and the murmurs. So the murmurs are not good sounds. So you'll be able to understand that these are murmurs which are not normal. Then the patient exhales and then holds breath during listening. So when the patient is listening, the patient may end up actually holding his breath. So when you're auscultating, you should be able to understand what is happening at that time, so that you can be able to interpret whether it is normal sounds or it is abnormal sounds. Then evaluation of other systems, the lungs, respiratory assessment, abnormal findings that are related to the CVD are and we talked about this all during the previous assessment or the previous lecture, where we talked about the respiratory system assessment. About the pulmonary edema, we mentioned something about. We also talked about crackles and then the atelectasis. So evaluation of other systems, especially the abdomen. We are going to have abdominal assessment as a topic, how you're supposed to assess the abdomen and so forth. So abdominal distension indicates ascites in late stage of heart failure. So when you get a patient who has been having a heart condition and he has come with abdominal distension, then you should suspect that your patient has advanced, and this can be a sign of heart failure. And when they get into heart failure, management becomes so complicated, and sometimes we fail to save these patients from these conditions. Then hepatojugular reflex, test for suspected right ventricular or biventricular heart failure. So you can also do this, and can help you to understand that your patient has actually gotten into heart failure. Then pulsatile kind of mass in the middle and the upper abdomen, which indicates abdominal aortic aneurysm. So this aneurysm is not also a good sign. So aneurysm of the aorta is actually a sign to show you that there is a problem in your patient's heart, or the heart is failing. So you should be able to know the reasons as to why you do some of these examinations or these assessments, and be able to articulate what you find out to what the condition could be. So systolic outbreath may also be heard over the mass. So all this can help you evaluate the condition of your patient. I want us to talk about this also, especially in the elderly. The gerontologic kind of considerations, what we consider in old age, the peripheral pulses. So the elderly patients basically they have palpable peripheral pulses due to a decreased artery elasticity and loss of adjacent connective tissues. And we said when someone grows old, all the systems in our bodies also degenerate, including the circulatory system, including the respiratory system, including the musculoskeletal and all other systems that I have not mentioned. They degenerate and their functioning will not be as someone who is still a young adult or a child. So their systems degenerate, and when you're palpating or when you're assessing their pulses, this is what you realize. There is palpable peripheral pulses, and it is due to that decreased artery elasticity. The arteries are decreasing their elasticity. So you can easily feel those peripheral pulses, and when you feel them, they are not as that of a young adult or middle-aged adult. So all the systems in our patients who are elderly are degenerated, and they don't actually present as you the person is. Sorry about that. Someone made a call in my phone and interfered. So, prolonged pressure on the toes or feet compromises arterial perfusion, leading to ulceration, infection, and gangrene. So, as I've mentioned already, most of our patients who come at this elderly age, they always present, but when they present to us, let's not say that maybe they have a complication or they have a problem, but let's first look at the age and compare with the condition. Then cardiovascular changes in elderly, isolated systolic hypertension, they have it. Most of the patients who are elderly have this condition. So it is common in elderly, associated with cardiovascular morbidity and mortality. So this condition always kills these elderly patients. So high risk of postural hypotension due to decreased postural reflex sensitivity. So our patients always, they get hypotension when they change the position. If the patient was seated, that old man was sitting, you took the pressure, it was okay. But when he suddenly stands, the position changes, and therefore even the blood pressure may lower. So this is what they call the postural kind of hypotension, because the patient has changed our position. Then considerations are before prescribing new cardiovascular medications. We should always put this in consideration before we say this patient has failed with this condition, let's change to these drugs. It might be just because of the state of the patient at that time, which has made maybe that condition to change in that manner. So you should not change the drugs immediately before assessing. So there is high risk of postural hypotension due to decreased postural reflex sensitivity. So as I mentioned earlier on in the previous slide, most of our clients who are elderly, all the systems in the bodies degenerate, and their functionability is not the same as someone who is still young. So what could be the challenges in relation to examining this cardiovascular system in relation to the elderly? Palpation and auscultation are difficulties. It is difficult to palpate some of these patients. The chest, you try to look for maybe the heart murmurs, you cannot get them just because they are very thin and very low, so you may not feel it when you try to put even your fingers to palpate. So detecting these heart sounds may be very difficult for you, just because you cannot access them. They are very thin and deep, so you may not be able to feel them. Then changes in the chest shape, chronic obstructive lung disease can also be there. And then the spinal deformities, the kyphosis can also be a problem. Sclerosis, kyphoscoliosis can be one of the conditions that affects always the old age. You find that the chest is not broad as that of an adult for the case of the old, so it may be curved and it forms that kind of curve whereby you cannot access what you need to access. So this kind of deformities on the chest, on the spinal cord, because you see how the old people move. You find somebody who has been walking straight is walking when he's bent. So that is what happens on the spinal cord around the thoracic region, and the patient walks like he's bending, and therefore you cannot also access some of the areas that you needed to access within the thoracic region or around the chest because of that kyphoscoliosis kind of a deformity in that age of the elderly. So we have to look at all this, and we shall be able to see that it's not easy to examine a patient who is an elderly person. So you have to be very keen, and also have to take your time to be patient with them. Otherwise, you may not get the right information, you may not be able to get the right assessment from these patients. So the purpose of laboratory tests, why do we do this? So we do this in order to identify the cardiovascular signs and symptoms that are and also the causes. So we need this because it can help lead us to the right diagnosis. Then assess the blood abnormalities affecting the CVD prognosis. So there can be a problem, either a lot of proteins, or it can be due to lipids. So the lipids can also be one of the issues affecting the coronary vessels, and this can lead to the heart conditions. So you can be able to do all this and can show you some of the blood abnormalities, and you'll be able to handle in relation to the cardiovascular disease and look at the prognosis of your patient. Evaluate inflammation degree. So you have to know how much the inflammatory effect has affected the blood vessels or the heart, and how much are you supposed to do to save the life of your patient. So when you look at the cardiac biomarker analysis, you have to look at the plasma levels of the cardiac biomarkers. So this can help you understand the level of the conditions and what you can do as a health worker to save the life of your patient in relation to the management. So diagnosis of acute MI in conjunction with the history. So you get the history, you do physical examination and the ECG. So some of the biomarkers can be myoglobin, the troponin 2, and I, T and I, with specific timelines for rise, peak, and return to normal. So you have to know all this. At what time does it go high? At what time does it get to normal? What is the peak of these biomarkers and so forth? Because if you don't know them, then you cannot be able to understand the real condition of your patient and have to go about with it. So the importance is early and late diagnosis of acute MI. So you have to know all this so that you can be able to manage your client. So the lipid profile and other blood tests, as I mentioned, is very important, especially the cholesterol levels are very important. So you have to know the cholesterol levels of your patient, the low and then the high cholesterols. So you have to know which one is normal and which one is not normal. If a patient has low cholesterol, what happens? If the patient has a high cholesterol, what happens? So you should be able to understand the ratios of all these different types of cholesterol so that you can be able to understand whether your patient is having a more impact to the heart due to the high levels of cholesterol or due to the low levels of cholesterol and so forth. So when you don't know what these biomarkers indicate, then you may also not be able to understand what is happening with your patient. So for this case, I request that Let's try to research more. Let's try to read more on the biomarkers of the heart. Let's try to understand what does LDL mean, what does the HDL mean, so that we can be able to understand that if a patient comes and we do this kind of test in relation to the cholesterol, what does it mean if a patient comes with LDL, if a patient results HDL, what does it indicate, and what should I do for this patient? Besides that, we also need to know about the other blood tests, and the other blood tests are here as indicated. We have to do the C-reactive proteins for inflammation prediction, and this one can show that there's inflammation taking place somewhere. And then also we have to do something in relation to the brain to understand the heart failure diagnosis, so that we can be able to prevent a stroke. Then we also have to do electrocardiogram, and this one is basically one of the key investigations that we need to do. This one is not a blood test, but this one is basically done in relation to the ECG machine, and to give you the readings, and the doctors are able to interpret. So we have the radiologists who are able to interpret some of these readings, and they will be able to tell you what is happening with your patient. So the ECG is one of the most used kind of investigations for our patients. So you have to continue monitoring these patients depending on the findings of the ECG. So some of them, they can interpret for you instantly, but sometimes there are those ones which can take some time depending on what you really want to find out from the patient. So this one is one of the most diagnostic kind of investigations for patients with cardiovascular conditions. So for the diagnosis for this, it may show you arrhythmias, it may show you some of the abnormalities, it may show you the myocardial kind of either infarctions and so forth. So there you can be able to see and also plan for the management of your patient. So other challenges and considerations in relation to the blood test. So artifact causes, false alarms, proper skin preparation, and electrode changes are crucial. So you should be able to change these electrodes, especially during the ECG. And it's very key for you to do that so that you don't either misread or you don't get wrong impressions of these results. So it's key for you to also prepare the skin, because these leads are put on the skin, and when they are put on the skin, they should be able to read what is happening in the heart, and be able to interpret according to the findings. So these electrodes should be changed, and the skin should be clean and well prepared for attachment of the electrodes to give you the proper readings, especially in the ECG investigation or assessment. Then nurse-patient communication on monitoring purpose and limitations. So it's also very key for you to communicate with your patient, especially during these tests, because some of them may come when they are completely very negative, indicative of a bad heart or a heart failure, which is really a condition that everyone may not want to hear about it. So the way you communicate to your patients is also very vital for them, either to live longer and accept the condition, or for them to live in denial and regret and end up dying faster than you would expect. And then stress testing. How do you test for stress? So the purpose and the procedure for testing stress evaluates a cardiovascular response to increased oxygen and nutrient demands. So this will help you to evaluate the cardiovascular response. How is your cardiovascular system, or how is your patient's cardiovascular system responding to either increased oxygen and nutrient demands? So you should be able to assess all this. Then indicates also atherosclerosis, post-MI heart function, and medication effectiveness. Is your heart working well with certain drugs, or it is not functioning well? What should they do next? Is there anything that could be done better, or they change the medication? So medication effectiveness is also important, whether it is postly effective or not. Then exercise or pharmacologic stress test with a radionuclide imaging or echocardiogram. So you should also do this. And the patients can do exercise, and you see how is your patient responding in the time of doing exercise. How is your patient feeling? What is the response of the patient? And you can do this, then after you do also the ECG and find out how the heart is responding with this stress of the exercise. What could be the nursing interventions? Having talked all this, we need to know how you are going to intervene as a health worker, as a nurse. So nursing interventions basically look at what you're going to do, your response towards the condition of your patient. So patient preparation. So you have to avoid stimulants, avoid fasting, then appropriate clothing for your patient. Then monitoring signs and symptoms during the test. You have to monitor. How is the patient? You have to look at your patient and see, is the patient breathing well? Is there difficulty in breathing? Is the patient expressing pain? So when these tests are going on, you should be able also to monitor the signs and symptoms of the patient and can tell you how the patient is coping up with the stress during the time of the procedure. Then positive stress test indicates further testing. So the positive stress test indicates further testing. So if you've tested your patient and the patient has responded positively to any stress, then you can go ahead and do any other test so that you can be able to know, is your patient able to adjust when it is this kind of stress and is responding positively. What about now if I add on to this other one? How is he going to respond? And this can show you that your patient is actually either not doing so bad or is improving. So this is the end of our session for this afternoon. I don't know whether it is already evening. So this is the end of our session, and I think if time allows, we shall have another session later in the course of the day. So basically, I want to encourage us to go and read more, to research more, because cardiovascular conditions are very common. Most of our patients come with these conditions, but because we don't give time for proper and adequate health assessment, we end up missing them out. And these conditions have killed most of our patients when we do not know. Sometimes they say somebody has been walking, somebody was able to do some activities at his home, went even to work, but from nowhere they heard that he collapsed. So this can be the hidden conditions of the cardiovascular system, which may have not been actually identified and managed in time. So I want to encourage all of us to have time to assess our patients when they come to us. Give time to your patient, get detailed information about your patient so that you can be able to manage them appropriately and reduce mortality due to some of these chronic conditions. So thank you very much, and I think we have come to the end of our session for now. Thank you.